Question 1. What is the recommended chest compression rate for adults during high-quality cardiopulmonary resuscitation, CPR? A. 60 to 80 compressions per minute. B. 80 to 100 compressions per minute. C. 100 to 120 compressions per minute. D. 120 to 140 compressions per minute. Answer: C. 100 to 120 compressions per minute. This question focuses on a critical aspect of high-quality CPR, the proper compression rate. The keyword recommended highlights the adherence to current AHA guidelines. To circulate blood effectively, chest compressions must be delivered at a rate of 100 to 120 compressions per minute, which is fast enough to maintain perfusion without causing rescuer fatigue too quickly. Imagine a steady, rhythmic beat, like the song "Stayin' Alive", to help maintain the correct pace. Always push hard and fast for effective chest compressions. Question 2. A patient in cardiac arrest has a rhythm of pulseless ventricular tachycardia, private, on the monitor. What is the most appropriate initial electrical therapy? A. Synchronized cardioversion. B. Asynchronous defibrillation. C. Transcutaneous pacing. D. Automated external defibrillator, AED, analysis and shock if advised. Answer: B. Asynchronous defibrillation. This question tests your understanding of cardiac arrest rhythms and appropriate electrical therapy. The critical clue is pulseless ventricular tachycardia, which is a shockable rhythm in a patient without a pulse. Asynchronous defibrillation, meaning the shock is delivered immediately without synchronization, is the correct treatment for pulseless rhythms like private or ventricular fibrillation. Synchronized cardioversion is used for unstable patients with a pulse, while transcutaneous pacing is for symptomatic bradycardia. Remember, if there's no pulse, it's a defibrillation situation, not synchronized cardioversion. Question 3. What is the primary drug used in all shockable and non-shockable cardiac arrest rhythms? A. Amiodarone. B. Lidocaine. C. Atropine. D. Epinephrine. Answer: D. Epinephrine. This question assesses your knowledge of core pharmacotherapy in cardiac arrest. The keyword primary drug signals that you should identify the most consistently used medication across various arrest rhythms. Epinephrine is crucial because it increases blood flow to the heart and brain through its vasoconstrictive effects, improving the chances of return of spontaneous circulation, ROSC, in both shockable rhythms, like VF/private, and non-shockable rhythms, like asystole/PEA. Think of epinephrine as the cornerstone drug for all cardiac arrest scenarios. Question 4. What is the recommended initial dose of adenosine for stable narrow complex tachycardia? A. 1 mg 4 push. B. 3 mg 4 push. C. 6 mg 4 push. D. 12 mg 4 push. Answer: C. 6 mg 4 push. This question evaluates your recall of specific medication dosages in the ACLS algorithm, particularly for stable narrow complex tachycardia. The keywords initial dose and stable narrow complex tachycardia are important. Adenosine works by temporarily blocking the electrical conduction in the AV node, effectively interrupting re-entry pathways that cause these rapid heart rates. The first dose is 6 mg, administered rapidly, followed by a flush, and if unsuccessful, a second dose of 12 mg may be given. Remember this sequence. 6 mg first, then 12 mg if needed. Question 5. What is the target partial pressure of arterial carbon dioxide, PACO2, range for adult patients post-cardiac arrest. A. 25 to 30 millimeters of mercury. B. 30 to 35 millimeters of mercury. C. 35 to 45 millimeters of mercury. D. 45 to 50 millimeters of mercury. Answer C. 35 to 45 millimeters of mercury. This question pertains to post-cardiac arrest care, specifically ventilatory management. The keyword target indicates an optimal range for maintaining physiological stability. Maintaining PACO2 between 35 to 45 millimeters of mercury, which is the normal physiological range, helps prevent both hyperventilation, which can decrease cerebral blood flow, and hypoventilation, which can cause acidosis and increase intracranial pressure. Balancing oxygenation and ventilation is critical for improving neurological outcomes after cardiac arrest. Aim for normal CO2 levels to best support brain recovery. Question 6. What is the recommended action immediately after delivering a shock to a patient in ventricular fibrillation? A. Check for a pulse. B. Resume chest compressions. C. Administer 1 mg epinephrine. D. Assess airway patency. Answer B. Resume chest compressions. This question tests a critical step in the cardiac arrest algorithm, emphasizing continuous chest compressions. The keyword immediately after delivering a shock is a strong clue. After defibrillation, there should be no delay in resuming high-quality chest compressions for a full 2 minutes, as this provides vital blood flow to the heart and brain, even before assessing for a pulse. Delaying compressions to check for a pulse reduces perfusion and decreases the chances of successful resuscitation. Remember, shock, then immediately continue CPR. Question 7. A patient presents with symptomatic bradycardia unresponsive to atropine. What would be the next most appropriate intervention? A. Administer adenosine. B. Initiate transcutaneous pacing. C. Prepare for synchronized cardioversion. D. Administer amiodarone. Answer B. Initiate transcutaneous pacing. This question assesses your understanding of the bradycardia algorithm. The crucial information is symptomatic bradycardia and unresponsive to atropine, indicating that initial pharmacological treatment has failed. When atropine is ineffective for symptomatic bradycardia, the next step is to initiate transcutaneous pacing, TCP, to electrically stimulate the heart and increase the heart rate. Pacing directly addresses the slow heart rate, providing symptomatic relief until more definitive treatment can be arranged. Think of TCP as the electrical backup when medications don't work for slow, symptomatic rhythms. Question 8. What is the proper technique for opening the airway of an unresponsive trauma patient? A. Head tilt chin lift. B. Jaw thrust. C. Chin lift only. D. Hyperextension of the neck. Answer B. Jaw thrust. This question focuses on airway management in a specific patient population, highlighted by the keyword trauma patient. In any patient with suspected cervical spine injury, the head tilt chin lift maneuver is contraindicated because it can extend the neck and worsen spinal cord damage. The jaw thrust maneuver, by lifting the jaw forward without extending the neck, effectively opens the airway while minimizing cervical spine movement. Always protect the spine in trauma patients by using the jaw thrust. Question 9. What is the maximum recommended dose of epinephrine that can be given for anaphylaxis? A. 0, 1 mg. B. 0, 3 mg. C. 0, 5 mg. D. 1 milligram. Answer, C. 0.5 mg. This question tests your knowledge of a specific scenario requiring epinephrine, distinguishing it from cardiac arrest dosing. While the question asks for the maximum recommended dose, the standard initial dose for anaphylaxis is 0.3-0.5 mg intramuscularly, IM, typically repeated every 5 to 15 minutes if symptoms persist. In anaphylaxis, epinephrine is used for its vasoconstrictive and bronchodilatory effects. For adults, 0.5 mg is considered the maximum single dose administered IM in a non-cardiac arrest setting. Remember that anaphylaxis often uses IM epinephrine, not the 4 route used in cardiac arrest. Question 10. During continuous quantitative waveform capnography in cardiac arrest, a sudden increase in end-tidal carbon dioxide, EtCO2, to 40 mm of mercury suggests which of the following? A. Esophageal intubation. B. Hypoventilation. C. Return of spontaneous circulation, ROSC. D. Ventilator malfunction. Answer, C. Return of spontaneous circulation, ROSC. This question delves into the use of capnography as a critical monitoring tool during resuscitation. The keywords sudden increase in EtCO2 and 40 mm of mercury are strong indicators. During CPR, EtCO2 levels are typically low. A sudden, sustained increase to normal physiological levels, around 35 to 45 mm of mercury, is a reliable sign of return of spontaneous circulation, ROSC, meaning the heart has started beating effectively again and is circulating blood to the lungs. This surge in CO2 indicates that blood flow is improving, allowing more CO2 to be delivered to the lungs for exhalation. Question 11. What is the recommended treatment for torsades de pointes? A. Amiodarone. B. Lidocaine. C. Magnesium sulfate. D. Procainamide. Answer, C. Magnesium sulfate. This question tests your knowledge of a specific, life-threatening arrhythmia and its unique treatment. Torsades de pointes is a polymorphic ventricular tachycardia characterized by a twisting appearance on the ECG, often associated with a prolonged QT interval. The specific treatment for torsades de pointes is intravenous magnesium sulfate, which helps stabilize cardiac cell membranes. Recognizing this distinct rhythm and knowing its specific remedy is crucial for effective ACLS care. Think M for magnesium and M for munificent torsades treatment. Question 12. What is the initial recommended defibrillation dose for adult biphasic defibrillators for VF/private? A. 50 to 100 joules. B. 120 to 200 joules. C. 200 to 300 joules. D. 360 joules. Answer, B. 120 to 200 joules. This question focuses on the correct energy settings for defibrillation, specifically with biphasic defibrillators. The keywords initial recommended defibrillation dose and biphasic are key. Biphasic defibrillators deliver energy in 2 phases, which allows for lower energy levels to be effective compared to monophasic devices. The initial dose for biphasic is typically 120 to 200 joules, whereas monophasic would be 360 joules. If the first shock is unsuccessful, subsequent shocks should be at an equivalent or higher dose. Question 13. What is the appropriate depth for chest compressions in an adult during CPR? A. At least 1 inch, 2, 5 cm. B. At least 1, 5 inches, 3, 8 cm. C. At least 2 inches, 5 cm. D. At least 2, 4 inches, 6 cm. Answer, C. At least 2 inches, 5 cm. This question is a fundamental review of high-quality CPR components, specifically the correct compression depth. The keyword appropriate depth highlights a crucial metric for effective blood circulation. Chest compressions should be at least 2 inches, 5 cm, deep but no more than 4 inches, 6 cm, to ensure adequate blood flow to the brain and heart without causing undue injury. Pushing deep enough is just as important as pushing fast enough. Question 14. Which of the following is a common reversible cause of cardiac arrest, one of the H's? A. Hypoglycemia. B. Hypertension. C. Hypovolemia. D. Hypernatremia. Answer, C. Hypovolemia. This question tests your knowledge of the H's and T's, which are reversible causes of cardiac arrest. The keyword reversible cause directs you to identify one of these treatable conditions. Hypovolemia, meaning low blood volume, is a critical H that can lead to cardiac arrest, and it can often be corrected with fluid administration. Recognizing and addressing these underlying causes, like significant blood loss, is vital for successful resuscitation. Question 15. A 55-year-old male presents with acute chest pain, ST segment elevation on his ECG, and diaphoresis. What is the initial priority in his management upon arrival at the emergency department? A. Administer oral aspirin. B. Prepare for immediate defibrillation. C. Obtain a detailed medical history. D. Administer 4 fluid bolus. Answer. A. Administer oral aspirin. This question describes a patient presenting with symptoms highly suggestive of acute coronary syndrome, ACS, and specifically ST elevation myocardial infarction, STEMI. The keyword initial priority is key. While all options have a place, prompt administration of aspirin, 162-325 mg non-enteric coda D, is a critical initial intervention for ACS to inhibit platelet aggregation and prevent further clot formation in the coronary arteries. Time is muscle, and aspirin works quickly to limit damage. Question 16. What is the correct ratio of compressions to ventilations for a single rescuer performing CPR on an adult? A. 15:2. B. 20:2. C. 30:2. D. 5:1. Answer, C. 30:2. This question assesses your foundational BLS knowledge regarding the correct compression to ventilation ratio for adults. The key phrase, single rescuer performing CPR on an adult, is important here. For adults, whether by 1 or 2 rescuers, the recommended ratio is 30 compressions followed by 2 breaths. This ratio balances the need for continuous chest compressions with adequate ventilation. Remember, push hard, push fast, and give good breaths. Question 17. In the management of symptomatic bradycardia, if atropine is ineffective and transcutaneous pacing is unavailable or ineffective, what is the next drug option? A. Adenosine. B. Amiodarone. C. Dopamine or epinephrine infusion. D. Lidocaine. Answer, C. Dopamine or epinephrine infusion. This question delves deeper into the symptomatic bradycardia algorithm, focusing on pharmacologic options when initial treatments fail. The scenario states atropine is ineffective and transcutaneous pacing is unavailable or ineffective, pointing towards the need for a continuous medication infusion to increase heart rate. Dopamine or epinephrine infusions are recommended to provide chronotropic, heart rate increasing, support in persistent symptomatic bradycardia. These infusions can maintain the heart rate and blood pressure until definitive treatment can be arranged. Question 18. What is the recommended post-cardiac arrest care target systolic blood pressure for patients with return of spontaneous circulation, ROSC? A. Above 80 mm of mercury. B. Above 90 mm of mercury. C. Above 100 mm of mercury. D. Above 120 mm of mercury. Answer, B. Above 90 mm of mercury. This question focuses on an important goal in post-cardiac arrest care to ensure adequate organ perfusion. The keyword target systolic blood pressure emphasizes a specific physiological aim. After ROSC, it is crucial to maintain a systolic blood pressure of at least 90 mm of mercury or a mean arterial pressure, MAP, of 65 mm of mercury to prevent secondary brain injury and ensure perfusion to vital organs. Achieving this blood pressure helps optimize recovery by supporting cerebral and coronary blood flow. Question 19. What is the maximum interruption time for chest compressions during CPR? A. 5 seconds. B. 10 seconds. C. 15 seconds. D. 20 seconds. Answer, B. 10 seconds. This question highlights a critical aspect of high-quality CPR, minimizing interruptions. The keyword maximum interruption time underscores the importance of continuous compressions. The AHA guidelines strongly emphasize that chest compressions should be interrupted for no more than 10 seconds for any reason, such as rhythm analysis or pulse checks. Longer interruptions significantly reduce blood flow to the brain and heart, diminishing the chances of survival. Always strive for continuous compressions. Question 20. What is the primary method to confirm proper placement of an advanced airway device, e.g., endotracheal tube, during cardiac arrest? A. Bilateral chest rise. B. Auscultation of breath sounds. C. End-tidal carbon dioxide, EtCO2, detection. D. Condensation in the tube. Answer, C. End-tidal carbon dioxide, EtCO2, detection. This question assesses your knowledge of airway management and verification techniques. While other options like bilateral chest rise and auscultation are important, the keyword primary method points to the most reliable technique. Continuous waveform capnography, EtCO2 detection, is the most reliable method to confirm and monitor correct endotracheal tube placement, as CO2 is exhaled from the lungs, not the esophagus. If you see sustained EtCO2, you can be confident the tube is in the trachea. Question 21. Which of the following is a common non-shockable cardiac arrest rhythm? A. Ventricular fibrillation, VF. B. Pulseless ventricular tachycardia, private. C. Asystole. D. Torsades de pointes. Answer, C. Asystole. This question tests your ability to differentiate between shockable and non-shockable rhythms, a fundamental concept in ACLS. The keyword non-shockable cardiac arrest rhythm guides you to identify a rhythm where defibrillation is not indicated. Asystole, often appearing as a flat line on the ECG, represents a complete absence of electrical activity in the heart, and therefore, defibrillation will not be effective. The primary treatment for asystole and PEA is high-quality CPR and epinephrine. Question 22. What is the purpose of targeted temperature management, TTM, in post-cardiac arrest care? A. To prevent hypothermia and shivering. B. To induce hyperthermia to kill bacteria. C. To improve neurological recovery. D. To speed up metabolic processes. Answer, C. To improve neurological recovery. This question focuses on a key intervention in post-cardiac arrest care. The keyword purpose asks for the primary goal of TTM. Targeted temperature management, typically inducing mild hypothermia, 32 degrees C 36 degrees C, for at least 24 hours, is used to protect the brain and improve neurological outcomes for patients who remain comatose after return of spontaneous circulation. It works by reducing the brain's metabolic demand and minimizing reperfusion injury. Think of TTM as a protective measure for the brain after a traumatic event like cardiac arrest. Question 23. A patient presents with a regular narrow complex tachycardia at a rate of 160 bpm and is stable, no signs of instability. After vagal maneuvers are attempted and fail, what is the next recommended intervention? A. Synchronized cardioversion. B. Administer 6 mg adenosine for push. C. Administer 1 mg epinephrine for push. D. Prepare for transcutaneous pacing. Answer, B. Administer 6 mg adenosine for push. This question tests your knowledge of the stable tachycardia algorithm. The clues regular narrow complex tachycardia and stable are crucial, indicating that the patient has a pulse and no signs of shock, chest pain, or altered mental status. After attempting vagal maneuvers, the next step in managing stable narrow complex tachycardia is to administer 6 mg of adenosine for push. Adenosine helps to slow down or temporarily block the AV node, often revealing the underlying rhythm or terminating the tachycardia. Question 24. What is the standard dose of amiodarone for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, after a third shock? A. 150 mg for bolus. B. 300 mg for bolus. C. 1 mg per minute for infusion. D. 5 mg per kilogram for bolus. Answer, B. 300 mg for bolus. This question specifically addresses the use of antiarrhythmics in cardiac arrest. The keywords refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, private, after a third shock indicate that initial defibrillation and epinephrine have not been successful. In this scenario, the first dose of amiodarone is 300 mg for bolus, which is given to help suppress the electrical irritability of the heart. If VF/private persists, a second dose of 150 mg amiodarone can be given. Question 25. Which of the following is a sign of effective ventilation using a bag mask device? A. Gastric distension. B. Audible stomach gurgling. C. Visible chest rise and fall. D. Decreased oxygen saturation. Answer, C. Visible chest rise and fall. This question focuses on the practical skill of bag mask ventilation. The keyword effective ventilation directs you to identify a clear indicator that air is entering the lungs. Visible chest rise and fall is the most direct and easily observable sign that you are successfully delivering breaths into the patient's lungs. Other signs like gastric distension or gurgling indicate air entering the stomach, which is ineffective and potentially harmful. Question 26. When is synchronized cardioversion indicated? A. For pulseless ventricular fibrillation. B. For asystole. C. For unstable tachycardia with a pulse. D. For pulseless electrical activity. Answer, C. For unstable tachycardia with a pulse. This question tests your understanding of synchronized cardioversion, a key electrical therapy. The crucial phrase is unstable tachycardia with a pulse, meaning the patient has a fast heart rate that is causing symptoms like hypotension, altered mental status, or signs of shock, but still has a detectable pulse. Synchronized cardioversion delivers a shock timed with the R wave of the QRS complex to avoid inducing VF. This timing is essential to convert the unstable rhythm safely. Question 27. A patient presents with severe hypotension and cool, clammy skin after a suspected overdose. The ECG shows a wide QRS complex rhythm. What reversible cause should be considered? A. Hyperkalemia. B. Hypothermia. C. Hypoglycemia. D. Hypovolemia. Answer: A. Hyperkalemia. This question describes a specific clinical scenario that points to one of the H's and T's. The keywords overdose, severe hypotension, and wide QRS complex rhythm are significant clues. Overdoses of certain drugs, e.g., calcium channel blockers, beta blockers, tricyclic antidepressants, can lead to hyperkalemia, which classically presents with a widened QRS on ECG and can cause profound hypotension and cardiac arrest. Considering reversible causes is a cornerstone of ACLS. Question 28. What is the recommended method for assessing a pulse in an adult during CPR? A. Radial pulse. B. Brachial pulse. C. Carotid pulse. D. Femoral pulse. Answer: C. Carotid pulse. This question assesses a foundational skill in CPR, pulse assessment. The keyword recommended method guides you to the most reliable site for checking a pulse in an unresponsive adult. The carotid pulse, located in the neck, is generally the most accessible and palpable central pulse in an adult, even when peripheral pulses might be absent due to low blood pressure. Always check for a pulse for no more than 10 seconds. Question 29. What is the appropriate initial action when encountering an unresponsive adult in a non-healthcare setting? A. Call 911/emergency services. B. Check for a pulse and breathing. C. Begin chest compressions. D. Shout for help and activate the emergency response system. Answer: D. Shout for help and activate the emergency response system. This question refers to the initial steps in the chain of survival, particularly in a lay rescuer context. The keyword initial action points to the very first step upon discovering an unresponsive adult. Before doing anything else, it's crucial to ensure scene safety, then shout for help to get others involved, and immediately activate the emergency response system, e.g., call 911 or send someone to do so and get an AED. Early activation brings trained help and an AED sooner. Question 30. During a resuscitation attempt, effective team dynamics involve which of the following? A. A single leader making all decisions without input. B. Clearly defined roles and closed-loop communication. C. Rescuers taking breaks frequently to avoid fatigue. D. Random assignment of tasks based on availability. Answer: B. Clearly defined roles and closed-loop communication. This question emphasizes the importance of effective team dynamics in resuscitation, a core component of ACLS. The phrase effective team dynamics highlights the principles of high-performance teams. Clearly defined roles, e.g., compressor, airway, medication, prevent confusion, and closed-loop communication ensures that messages are sent, received, and understood, thereby minimizing errors and maximizing efficiency during a stressful event. Good teamwork means everyone knows their job and confirms tasks are completed. Question 31. What is the primary reason for performing chest recoil during CPR? A. To prevent rib fractures. B. To allow the heart to fully refill with blood. C. To compress the heart more effectively on the next compression. D. To assess for palpable pulses. Answer B. To allow the heart to fully refill with blood. This question focuses on another crucial aspect of high-quality CPR, chest recoil. The keyword primary reason asks for the most important physiological benefit. Allowing for full chest recoil means letting the chest wall return to its normal position after each compression. This action creates negative intrathoracic pressure, which helps the heart fully refill with blood, ensuring that each subsequent compression can pump a maximal amount of blood out to the body. Don't lean on the chest, let it spring back fully. Question 32. What is the recommended initial 4/IO dose of epinephrine for pediatric cardiac arrest? A. 0.01 mg/kg. B. 0.1 mg/kg. C. 1 mg per kilogram. D. 0.5 mg/kg. Answer A. 0.01 mg/kg. This question tests knowledge specific to pediatric resuscitation, which differs significantly from adult dosing. The keywords initial 4/IO dose and pediatric cardiac arrest are vital. For children, epinephrine is administered at a dose of 0.01 mg/kg, which is significantly lower than the adult dose and is crucial to prevent adverse effects like severe hypertension. Always remember to use weight-based dosing for pediatric patients to ensure safety and efficacy. Question 33. Which drug is commonly administered to symptomatic patients experiencing a type 1 Mobitz I? Second-degree AV block? A. Lidocaine. B. Atropine. C. Adenosine. D. Amiodarone. Answer B. Atropine. This question focuses on the pharmacological management of a specific type of symptomatic bradyarrhythmia. The clue: symptomatic patients experiencing a type 1 Mobitz I. Second-degree AV block points to a condition where the heart's electrical conduction is slowed. Atropine is typically the first-line medication for symptomatic bradycardia, including Mobitz I, as it increases heart rate by blocking the action of the vagus nerve. If atropine is ineffective, other treatments like pacing may be considered. Question 34. What is the recommended intravenous fluid bolus for a patient in hypovolemic shock who has achieved ROSC after cardiac arrest? A. 500 milliliters of 0.9% normal saline. B. 1 to 2 liters of 0.9% normal saline or lactated ringers. C. 250 milliliters of dextrose 5% in water. D. 50 milliliters of 3% normal saline. Answer B. 1 to 2 liters of 0.9% normal saline or lactated ringers. This question addresses fluid resuscitation in a specific post-cardiac arrest scenario. The keywords hypovolemic shock and achieved ROSC indicate the need to address circulatory volume. For patients in hypovolemic shock after ROSC, a rapid bolus of 1 to 2 liters of isotonic crystalloid solution, such as 0.9% normal saline or lactated ringers, is typically administered to restore circulating volume and improve blood pressure. Adequate fluid resuscitation is essential to maintain perfusion to vital organs. Question 35. A patient has a Glasgow Coma Scale, GCS, score of 8 after ROSC following cardiac arrest. What is the immediate priority for airway management? A. Insertion of an oropharyngeal airway, OPA. B. Bag mask ventilation. C. Endotracheal intubation. D. Nasopharyngeal airway, NPA, insertion. Answer, C. Endotracheal intubation. This question focuses on airway management in the critical post-cardiac arrest phase. The keyword GCS score of 8 is the critical clue, as a GCS of 8 or less typically indicates a compromised airway and an inability to protect it. Endotracheal intubation is the definitive airway management strategy for these patients, providing secure airway protection and optimal ventilation and oxygenation. Securing the airway is paramount to prevent aspiration and ensure adequate oxygen delivery to the recovering brain.